doubts regarding previous discussions, or some students might have asked few of the doubts they have, and we can just briefly consider those doubts, or you people may have some doubts regarding our discussion itself, last time's discussion. So let us just know if there is any doubt or anything to add on, that is also there. Now, because most of the things we discussed about the hypertensive disorders of pregnancy, their classification, then we also discussed about the pathophysiology of preeclampsia, early preeclampsia, late preeclampsia, the problems associated with preeclampsia, and also the different systems that are involved with the preeclampsia, and the severity of preeclampsia, and what complications the preeclampsia patients can develop. So all those things we just discussed in our previous discussions. And also we discussed about what all the investigations we are supposed to do for these preeclamptic mothers when they require any kind of surgery like cesarean section, or if they are induced for normal vaginal delivery, so they may require definitely labor analgesia, one of the indicated indications actually for hypertensive disorders of pregnancy. So those things. Now today we'll be discussing about the labor analgesia as such for in general, and also for these patients with preeclampsia, and also how to manage if they are posted for cesarean section, how to manage the anesthesia part. So let us discuss about the labor analgesia in this, because invariably if they are posted for normal vaginal delivery, or if they develop labor, it is not an indication for going in for cesarean section. Definitely all the majority of these women can be allowed for normal vaginal delivery. There is preeclampsia is not an indication for taking them up for general anesthesia, for cesarean section, and especially in maybe eclamptic mothers, or maybe mothers who have got coagulopathy, abruptio placenta, or such patients with complications. So they may require cesarean section. So definitely we may have to go for general anesthesia in such situations. And most of the time it is because of the obstetric indication, the cesarean section, rather than any anesthesia indication for cesarean sections. So just let us start with labor analgesia for these patients. And just one question for you, because anything when we start our discussions, it is always the history becomes very, very important. So who gave the first labor analgesia? Such any idea?
They gave to Queen Victoria. I
No,
forgot
Queen
who.
Victoria later. The first labor analgesia was given by whom? Because these are some of the questions we do ask you in the exam, because we know that many times you will not be able to answer. So just to give you more marks if you answer. So such questions are commonly asked. It was James Young Simpson. He was an obstetrician in United Kingdom, James Young Simpson. So he gave actually the first labor analgesia in 1847. Because 1846 it was demonstrated, isn't it, in October 16th in US by W.T.G. Martin about anesthesia itself. It was not labor analgesia, it was anesthesia itself. But in January 1847, the first labor analgesia was given by James Simpson using ether as a agent for labor analgesia in a mother who had prolonged labor because she had rickets. And, it was a successful labor analgesia. She delivered very well, but there was a lot of problem for James Young Simpson, because during those days, everybody thought that pain during labor should not be relieved because of some religious background. So then, as you said, definitely in later, John Snow administered labor analgesia using chloroform to Queen Victoria. That was in which year, Mithun? You were trying to tell something about Queen Victoria getting labor analgesia.
I don't know which year, sir, but I remember that Jon Snow had demonstrated successfully for.
And that was in 1852. 1852, for Prince Leopold was born by using labor analgesia by chloroform. So once Queen said that, she felt very nice and she did not feel any pain. And that's how, the clergy, everybody, there was hardly there was any resistance to labor analgesia from then onwards. Of course, she again wanted to have labor analgesia in 1857 for one more child. That was the ninth child, Princess Beatrice. So again, she wanted Jon Snow to come and then administer labor analgesia. But in the meantime, Jon Snow entered the labor room slightly late. So her husband, King George, I think, so he used his handkerchief, started pouring chloroform, and she had good labor analgesia. During those days, it was very simple, isn't it? One could use even their handkerchief and then start putting the open drop method of either ether or chloroform. So that's how labor analgesia became very, very popular. Of course, now it is one of the most popular methods, and we don't want any mother to have pain during her labor. And maternal request is the most important indication for labor analgesia. So other than maternal request, Mukhtar, can you just tell what are the other indications for labor analgesia as such? Other indications for labor analgesia.
Sir, one is in our pre-eclamptic patients, sir.
Yeah, all hypertensive disorders of pregnancy.
Hypertensive disorders of
Yeah,
pregnancy.
hypertensive disorders of pregnancy. Okay, fine. Any other indication?
Cardiac issue, patients with cardiac issues.
Yeah, any patient with systemic diseases. It may be cardiac, it may be respiratory, it may be neurological, any systemic disease. If the mother has, definitely it is an indication for labor analgesia, right? Fine. Then
multiple gestations, sir.
Yeah, multiple pregnancy is an indication, especially for, it may not be required for the first baby that comes out. It is for the subsequent babies, the twins or triplets. So otherwise they develop a lot of hypoxia because of retroplacental circulation afterwards. So that is another indication. Okay, fine. Then
prolonged labor.
Prolonged labor, very good. That is one more indication. Especially prolonged labor, if it is due to the uterine contraction, which is not proper, especially dysregulated uterine contraction with cervical dilatation. That is always there. Sometimes, as the uterus contracts, the cervix should dilate. Suppose if that is not there, uterus is contracting, cervix is not dilating. So in such situations also, labor analgesia will definitely help in dilating the cervix also and regulating the contractions and dilatation of the uterus and cervix respectively. So that is one of the indications, prolonged labor, right? Anything else?
VBAC, sir, trial labor following VBAC.
Yes, very good. So trial labor is also an indication for labor analgesia. So these are some of the indications for labor analgesia. Invariably, you may be asked about these indications. So once you know the indications, and hypertensive disorders of pregnancy is one of the most important indications. So now, if you want to go for labor analgesia, what are your goals for producing labor analgesia? You should have goals for everything, isn't it? What goals you should have for providing labor analgesia?
It should be congruent to the specific levels at that point of labor. Like, for example, in the first stage of labor, you have from T10 to L1, whereas the second stage it should be covering S2, S3, S4 as well.
That means you provide analgesia for all three stages of labor. That is what you are telling. It should be predictable, and it should provide analgesia for all the three stages of labor, whether it is first stage, second stage, or third stage. Okay, one goal, right? Then ease of administration.
It should be easy to administer.
Easy to administer, isn't it? So that is another goal. And the third important goal is you must be knowing about 3Ps. Whenever you talk about goals of labor analgesia, the 3Ps, P, capital P. What are these 3Ps? You should always keep in mind when providing labor analysis. You must have heard about passenger, passage, and
Yes.
passenger power or passenger passage and power, isn't it? So the passenger is the the fetus, and our labor analgesia should not produce any harm to the fetus when you are giving, like drugs from crossing across, producing neonatal respiratory depression, or even producing any other effects for the fetus. So you should always see that the fetus is protected when you are giving labor analgesia. Second thing is the passage. No, the passage should not be harmed. Like the uterus is not producing any contractions, or cervix is not dilating. So such problems should not occur. Third is the power. As far as the mother is concerned, especially the motor blockade should not be there. Absolutely, there should not be any motor blockade, so that the bearing down of the mother should not be prevented. So these are the 3Ps: power, passage, and the passenger. Okay, what are the other goals?
It should prevent adequate cut down of sympathetic stimulus.
No, that is already, that is what you use it for, isn't it? To reduce the
Patient should be able to ambulate when necessary.
Oh, that is okay. Or if you think that walking epidurals you want to practice, right? That means there should not be any motor blockade. There should not be any motor blockade. There should not be any hypotension, postural hypotension. There should not be any sensory blockade of the soles of the feet. So that is fine. And one more thing is, suppose if you want to convert for anesthesia, you should be able to convert it also. Whatever the analgesia, because analgesia is purely the pain relief. It may have some amount of sensory block, especially A delta and C fibers, but there won't be any motor blockade with analgesia. But if you want to convert it to anesthesia, so you should be able to provide enough motor blockade also for the surgeon to do the surgery. So these are some of the goals as such. One is, ease of administration, the predictability for all 3 stages of labor. That is another very important thing. Then you should always look after these 3Ps: passenger, passage, and the power. Next is there should not be absolutely no motor blockade. And the other thing is, you should be able to convert it into anesthesia if required. Because last time when we were discussing, you were also talking about something called as prophylactic epidural.
Yes,
that also can be an indication here also. The prophylactic epidural, especially when you do not want airway manipulation, when you are providing anesthesia for these patients, because airway is an extremely difficult airway, and there is aspiration risk also, and there is sympathetic stimulation during your airway manipulation. All these can be prevented if you have a functioning epidural, and you can just convert it into an anesthesia from analgesia. So many times for these women with preeclampsia with severe features, probably if there is no contraindication for placing an epidural, it's called as a prophylactic epidural. This also can be one of the indications for labor analgesia. So you can also give labor analgesia through that. So okay, now pain pathway also is one very important thing. You just mentioned about the pain pathway. Can you just give more details about the pain pathway? Who introduced this pain pathway? Again, I know you are not very good in your history. Who introduced the first pain pathway of labor? No. Not gate theory we were talking about, not that. So it is actually the first person who introduced was in 1937, John Cleland. John Cleland. Actually, he introduced this pain pathway of labor. Actually, how the first stage pain pathway, how it goes to the brain, and then how the patient feels the pain, and what happens during second stage. Actually, he introduced what was called as a two catheter technique during those days itself. So one catheter in the lumbar area, another catheter in the caudal epidural. So that he was using lumbar epidural for the first stage of and second stage of labor, and caudal epidural, especially the later part of the second stage of labor, or even during second stage of labor, he used to activate the caudal epidural, because we know the caudal epidural will look after the S234 there. So that's how he introduced this pain pathway. So we'll have to remember John Cleland's name always. Okay, so his son again in 1973, because afterwards nobody practiced this two catheter technique. But his son again, Cleland Jr., in 1970s, he popularized this two catheter technique. Of course, now we are not using two catheter technique, we are still using single catheter technique. But with single catheter, always there is a problem, especially for second stage of labor. So especially the S234 may not be covered very well with a single catheter at the lumbar area. So anyway, so Jen, can you just tell about, you said that the the first stage of labor, it is always T10, 11, 12, and L1. Is there, what kind of fibers carry this?
This is A delta and C fibers.
So C fibers, especially
slow pain, and A delta is fast pain.
it is always the visceral pain, isn't it? So majority of the times, the first stage of labor is visceral pain. That is mainly because of the contraction of the uterus. And this pain is carried through the, afferent sympathetics, especially A delta and C fibers, mainly C fibers, which carry. So they are the sympathetic afferents. And second stage of labor is again by the, which actually, is it somatic or visceral pain?
Somatic.
Yeah, it is, second stage is more of course, visceral pain will also be there. Contractions of the uterus will also be there. But now predominantly, in second stage, it is the somatic pain. So somatic pain, which fibers carry this?
A delta.
No, A delta is okay, but there at the site of the pain, which nerve gets actually stimulated there? It's important for carry.
Pudendal nerve, sir.
Pudendal nerve. Pudendal nerve is a branch of which plexus?
Sacral plexus. S234.
So you should, in the exam, you can definitely tell sacral plexus, the pudendal branch, that is S234, that whole of the perineal area, and also the lower part of the cervix is supplied by this pudendal nerve. So it carries the pain. So again, why should you, and again after that, these, the fibers will carry the pain and relay in the spinal cord, isn't it? In substantia gelatinosa, and also the lamina 5 of the spinal cord, they relay the pain there. From there, how it travels to the brain?
From there is a release of substance P, sir. From there, that is the first order neuron. From there, it crosses to the other side, and then goes through spinal thalamic tract to the thalamus. And from the thalamus, it goes to the sensory cortex, sir. Somatosensory cortex. So this is the pain pathway, and as a feedback mechanism, again from the periaqueductal gray area, it comes and inhibits the release of substance P in the lamina and the spinal cord.
No, that is descending pathway. Descending inhibitory pathway, that is called. So invariably, you will be asked in the exam about the pain pathway. So you should remember that. And also, why should you know that in the first stage, it is only so T10 to L1, and later in second stage or later part of first stage and second stage, it is more of somatic pain. Why should we know about this? First stage is visceral, second stage is more somatic. So what is the importance of knowing about this particular thing?
Because somatic pain is not addressed as well by non-pharmacological methods. So we should resort to, or epidural is better for somatic pain.
No, that is okay. Even with your regional anesthesia I'm talking about. Any problem even with your regional anesthesia regarding the visceral pain and then the somatic pain? Any idea, Mukhtar?
There's pairing of sacral nerves in the epidural while providing epidural.
No, one thing we should realize that whenever we want to give analgesia, especially using our regional anesthesia techniques, so we should always remember that local anesthetics are very good for somatic pain. They are not at all very good for visceral pain. And for visceral pain, especially the C fibers are highly resistant for local anesthetic effect. So whereas opiates are very good for the visceral pain or the C fibers, they can easily block the C fiber transmission of pain. So that's why a combination of both local anesthetics and opiates definitely would be ideal to produce very good predictability of relief of pain for these mothers. So that's how, till probably 1970s or 1980s also, we're not using any opiates. We are using only local anesthetics. So after 1990, early 1990s, we started using the combination of opiates with local anesthetics. That's how, there was a better pain relief for the, during labor. One. The second thing is we were able to reduce the concentration of local anesthetics. I still remember when I was giving labor analgesia in 1990s, I was using 0.25% bupivacaine along with tramadol because, we did not have fentanyl. So I had to use a higher concentration. So any higher concentration can produce motor blockade, isn't it? So that's how, during those days, the incidence of cesarean section was very high. Now we were able to go for very low concentration of local anesthetics, like even 0.0625% of bupivacaine or even 0.05% bupivacaine, so that we could avoid or we can avoid motor blockade. And that is one of the goals also, to avoid motor blockade. So that is mainly because the addition of opiates. And that is the one thing because of the pain pathway and which fibers carry which kind of the pain. So we will be able to know what kind of drugs we have to use for even for regional anesthesia techniques. So that is always there. Okay, so now let's go into what are the different methods of labor analgesia. How you classify the methods of labor analgesia, because you may be asked again this also, because sometimes many of the women may not want regional analgesia techniques, isn't it? So then you may have to resort to non-regional analgesia techniques, and also maybe even non-pharmacological techniques sometimes. Can you just classify and then just let me know? Just enumerate.
The labor analgesia can be broadly classified into two, sir: non-pharmacological and pharmacological.
Okay, okay.
In pharmacological, it can be further divided into regional and systemic.
Okay.
Regional, we have central
So
neuraxial.
again, in non-pharmacological. Okay.
With types are there.
Okay. One by one, you just tell. Okay, right. Non-pharmacological and pharmacological. Pharmacological, you said that systemic analgesics and regional analgesia. Right.
In regional, central neuraxial as well as nerve blocks.
Okay, very good. Very good.
And in systemic, we have intravenous and inhalational.
Right.
Intravenous is again
First, enumerate the non-pharmacological method. Enumerate. You don't have to go into details.
First is Labore and Lama's method of psychoprophylaxis.
Psychoprophylaxis, right? Very good. Then
hypnosis.
Hypnosis, self-hypnosis, heterohypnosis.
Heterohypnosis.
Right, right. Okay.
Then we have transcutaneous electrical nerve stimulation, sir.
Hence, Wall and Melzack theory, that there, right.
Then there is acupuncture and acupressure.
Acupuncture, right.
Then there is hydrotherapy.
Yeah, hydrotherapy, like making the mother to sit in a bathtub, having warm water.
Warm water and delivering into that.
Warm water will be very soothing And also she can deliver inside the warm water itself, 37-degree warm water. The baby also will not, will feel as if it's inside the mother's uterus only. Okay, that is fine. It is still being used in many other European countries. Okay, then?
Water injection, sir.
Yeah, sterile
Water
distilled
injection.
injections, isn't it? So that also is one of the methods. So you may be asked to just enumerate these non-pharmacological methods. And as Mithun was talking about, these non-pharmacological methods are only good for first stage of labor. They're not good for subsequent part of the labor. Anyway, I just want to ask you, how do you classify the stages of labor?
First stage and second.
First, second, and third.
And fourth also.
Treatment, four stages are there, sir.
Okay, okay. What is this first stage?
First stage is from starting of
Is it-
labor to
Complete dilatation of the cervix.
Is it again subdivided, first stage?
Latent phase and active phase, sir.
Okay, very
Latent
good.
phase, they will be they won't be coordinated uterine contraction will not be there, whereas in active phase there will be a coordinated uterine contraction.
Okay, that is one difference. And from what time to what time is latent phase? Because you are talking about duration and the cervical dilatation.
Yes, sir.
Huh.
From onset of pain till beginning of cervical dilatation is latent phase, sir.
No, onset to 4 to 5 centimeters of cervical dilatation. Because, the latent phase is very, delayed. It takes a long time, latent phase. And once the 4 to 5 centimeter dilatation occurs, rapidly the progress of labor will start. And the mother would have gone for active phase of the first stage. And it is very short. And, rapidly she'll have a dilatation of, say, up to 10 centimeters within, say, half an hour to 1 hour. So whereas the latent phase may take 8 to 10 hours, especially in primary, it may take even 12 to 14 hours. That is always there. So active phase may take just about 1 hour, rapidly from 4 to 5 centimeter dilatation to reach 10 centimeter dilatation. Okay, what is the second stage?
From the dilatation of the cervix till delivery of the baby.
Okay, so
complete dilatation of cervix till delivery of the baby.
So what is the duration of this second stage?
Primary 1 hour, sir, and maybe multi, it will be 30 minutes.
Okay, and with epidural?
30 minutes.
How long you can wait with epidural? Is it delayed or is it short with epidural?
Short.
No, it is always prolonged. So if you have an epidural, you should convince obstetrician to wait for 2 hours maximum. So this is one thing is always there with epidural. So one can wait for up to 2 hours for second stage of labor, right? Then third stage is?
Delivery of the placenta.
Yeah, from the delivery of the fetus to the extraction of the placenta. Okay. Fourth stage?
So that is the first 1 hour after the expulsion of the placenta.
Yeah, why do we have this first 1 hour as the fourth stage? Why you should have this as the fourth stage?
For uterine relax.
If uterine contraction is not adequate.
No, it should continue to contract, isn't it? It should not relax.
Contract.
If
you relax, then you go into PPH. The first one.
What they have observed is, this is a recent one because Fredericks classified these stages of labor into 3 stages only. Later, this fourth stage has been added. And because, maximum number of complications occur in the first 1 hour after the third stage. That is why, the mother required to be observed. That is why you cannot just shift the mother once she has delivered the placenta. You have to keep her in the labor room under observation for any kind of complications she can develop. Then only she has to be shifted. So that is the idea behind the fourth stage. Okay, so first stage, as you know, that it is more of visceral, and that too till probably the latent phase, it's totally visceral type of pain. And afterwards, the visceral and somatic. And second stage is almost 80% it is somatic, 20% is visceral. So third stage hardly requires any analgesia as such. So that is what is your stages of labor and the analgesic requirements. Okay, now your non-pharmacological methods, they are not good for the active phase or even the second stage of labor because they'll not produce so much of good analgesia. But of course, they'll definitely increase the pain threshold so that overall the mother may not feel so much of pain. That is what they do. They'll just increase the pain threshold of the mother, whether it is psychoprophylaxis or hypnosis or TENS, whatever it may be. Okay, coming to the pharmacological methods, you are talking about the systemic drugs. What are the systemic drugs that are commonly used and which one is the most popular among them?
Pethidine.
So again, systemic means you just
opioids and opioids.
You classify them as systemically administered drugs and inhalational drugs. That is what you said, isn't it? Classification. So, and again, systemically administered drugs, opiates are the most popular drugs, of course. So, among the opiates, why you said pethidine? Pethidine is popular with you or with the obstetrician?
Obstetrician, sir.
Not with you. It is always, nowadays, tramadol also is quite popular among obstetricians. Why it is very popular with obstetricians, pethidine and tramadol?
It can be given IM.
That is the most important. Yeah, because IV, they are not so, want to go for IV, especially because they think that IV can produce immediate complications. They may not be able to handle. So if you are there, they can go for IV things because you are there to handle such any complications. But by themselves, they'll be usually giving either pethidine or tramadol with phenergan combinations in order to prevent any vomiting. So why pethidine other than intramuscular? Why any other advantage with pethidine? It has been found to decrease the duration of first stage of labor, pethidine. So that is why, pethidine is quite popular. But again, pethidine may not be ideal for second stage of labor or even the active phase of labor because pethidine, as you know, that it can only block the C fibers. It may not be able to block the A delta fibers, which are the somatic pain carrying fibers. So that's how, pethidine can be useful, but may not be an ideal choice. But if you want to give pethidine, so what should be your timing of giving the pethidine? No, because pethidine can easily cross the placental barrier. It can have a lot of depressive effect on the respiratory center of the neonate. So when you should at all, if you want to use pethidine?
The labor should be after 3 hours.
After
3 hours. 3 hours from injection of pethidine.
Administration, the labor should take place after. It is actually after 4 hours. Either it should be within 2 hours or after 4 hours. Because what they have found is the maximum effect of pethidine is between 2 to 4 hours after its administration on the neonate. So if labor occurs after 4 hours, not much of effect. And if the labor is immediately occurring within 2 hours, then also it is okay. So that is one important thing. And another important thing to know about pethidine is, especially the norpethidine, can have a prolonged half-life in the neonate. It can have nearly 24 hours half-life in the neonate. Whereas in adult population, it will have a maximum of 2 to 4 hours half-life. In a neonate, it can have a prolonged 24 hours half-life and can continue to produce neonatal respiratory center depression. That is why pethidine, what is the dose of pethidine that can be used?
10 mics per kg, sir. Adult.
No. It is not mics. Pethidine. Pethidine.
That is
milligrams, isn't it? Pethidine.
50 mg
milligrams.
25 to 50 mg.
1 milligram per kg body weight, intramuscular or intravenous. It is same because highly lipophilic drug. pethidine is same in whatever route you want to inject. So 50 milligrams can be given, but all the complications of opiate administration will be there with pethidine also, like respiratory depression of the mother, nausea, vomiting, pruritus, constipation, urinary retention. All these are generalized complications of whatever the opioids you use. So other than pethidine, of course, now pethidine you can rule out because you don't want to use pethidine. Definitely. What other drugs you can use? One can
use remifentanil, fentanyl,
Yeah.
morphine.
Yeah, fentanyl, remifentanil. Morphine you don't use again because of its prolonged duration of action and also prolonged respiratory depression in the mother as well as the neonate. So fentanyl, definitely you can still use fentanyl, short duration of action, but can produce neonatal respiratory depression. But what is the dose of fentanyl you can use?
Bolus 1 to 2 mics per kg, sir.
Yeah, usually 25 to 50 micrograms IV. And also you can run 1 mic per kg per hour infusion. So, but the problem with fentanyl, again, it can produce a lot of effects. All the side effects of opiates will be there, plus the effects on the neonate once it is born. So you also said the remifentanil. Remifentanil is becoming very, very popular, especially for those women where, there is a contraindication for regional anesthesia. We'll come to that. What are the contraindications for regional anesthesia? And in such patients and in such mothers, and also in those mothers who refuse regional anesthesia, analgesia. So one can definitely go for remifentanil. It's becoming very, very popular nowadays.
Yes,
so why remifentanil is becoming very popular?
Because the half-life is very small, sir. It's only 3 to 5 minutes because it gets metabolized by itself by plasma esterases. So we don't need, we won't expect any neonatal respiratory depression or any complications for the mother itself because it will get metabolized very fast.
Oh, what is the half-life of remifentanil? Does it cross the placental barrier?
It does cross the placental barrier, sir, but because of its reduced half-life, it gets metabolized in the fetus as well. So,
what is the half-life in the fetus?
3 to 5 minutes.
Again, it is same 3.5 minutes. 3.5 minutes in the mother and 3.5 minutes in the fetus as well. So as soon as the fetus is born, so it may have slightly, some amount of respiratory depression. If you just can manage that, afterward there won't be any prolonged respiratory depression, unlike the other opiates. So that's how, this is quite popular. So the thing is, what is the duration of analgesia with a single bolus dose of remifentanil? Duration of analgesia with single bolus dose. Like fentanyl, if you give, it acts for almost 45 minutes to 1 hour.
5 to 10 minutes.
It is 6 minutes. So duration of analgesia is just 6 minutes. So that is why there is no point in going for bolus. But still you can go for bolus injections, provided you have a parturient-controlled intravenous analgesia pump. So that she only can activate the pump anytime she wants analgesia, so that you have a lockout interval of 2 minutes also. And every time she activates the pump, she'll have a definite administration of a certain amount of the remifentanil. So that can be used. But you can also have a continuous infusion with parturient-controlled IV analgesia with remifentanil. So that is an advantage, isn't it? So when you want to go for intermittent boluses by the parturient and continuous infusion, what is the dose that is usually given?
0.5 mics per kg per hour, sir.
No, not per hour.
Per minute, sir.
No. It is 0.5 micrograms per kg bolus doses.
Okay, sir.
By herself, parturient controlled boluses can be 0.5 micrograms per kg body weight. And the infusion?
0.25 mics per kg.
Yeah, it can be
0.025 mics per kg per minute.
Per minute, 0.025 to 0.05 micrograms per kg per minute infusion also you can have. So with 2 minutes lockout interval. So that's how, remifentanil. But these patients have to be monitored because there were reported cases of respiratory arrest in maternal respiratory arrest has occurred when they were using remifentanil. So you have to continuously monitor the mother and the fetus when you're using remifentanil. That is always there, but it's quite popular. Ease of administration is very easy. But the thing is, you cannot convert that into anesthesia.
Yes.
Because that was also one of your goals when you were trying to select the particular technique of labor analgesia, isn't it? So that is fine. So now coming to inhalational anesthetics. So what are the inhalation anesthetics that you can use? That is
Entonox.
Yeah, Entonox. Okay, what is this Entonox?
Entonox is 50% nitrous oxide and 50% oxygen, sir.
Is it, you call it as Entonox when you administer through your anesthesia workstation? 50% oxygen and 50% nitrous oxide. Do you call it as Entonox?
No, sir.
When do you call it as Entonox?
It's coming from a single cylinder.
Very good. So both the gases should be in a single cylinder. I think last time we discussed about Ponting effect also. Did we discuss about Ponting effect? So
No,
because
sir.
now you have two gases. You cannot say gases because the critical temperature of nitrous oxide is 36.5. So it will remain as liquid normally. Whereas your oxygen critical temperature is minus 118 degrees centigrade. It remains as a gas at room temperature. But when both are mixed, so what happens to the liquid nitrous oxide?
The critical temperature of the mixture changes. So it becomes minus 6 degrees.
Yeah, minus 6.5. Yeah, correct. Okay,
so what happens is there is a chance in colder climates there is a possibility of the oxygen just getting consumed, but the nitrous being as a liquid form. So the patient initially just inhales the oxygen and then later on inhales a hypoxic mixture.
No, normally at 20 degrees, what happens to this mixture?
Separates and
Separate.
settles.
It will separate. Sir.
Nitrous separate.
20 degrees, I'm asking. 20 degree room temperature, what we are using?
20 degrees, it will be as a gas.
Both of that will be in a gas only. It is minus 6 degree is the critical temperature. Above critical temperature, you cannot compress any fluid into its liquid state. That is what is critical temperature. So now, what is this effect called as? The critical temperature of the higher critical temperature of one fluid will be reduced. It's Ponting effect, as you said. Yes, it's Ponting effect. And the problem is always there when these cylinders are stored in very, very cold places wherein the environmental temperature itself is less than minus 6 degrees centigrade. So then you'll have to shake it before administering. That is always there. So that is what is called as an Entonox. And do you require any special apparatus to give?
We need a demand valve masks so that whenever the patient takes a breath, that's when the gases get released and the patient will inhale the gases, as opposed to a normal mask which just keeps giving gases. So only when the patient takes a breath, she'll be able to inhale this gases from the cylinders.
Ideally, you should not use a continuous flow anesthesia workstation. Our anesthesia workstations the gases are continuously will be flown, and whereas with demand flow, it is only negative pressure of the patient or participant will open the valve. So that is there. So that is usually also used in dental analgesia. The Mackeson's machine, which has this advantage, can be used. So one problem as such is a specialized equipment is required. If it is a continuous flow, unnecessarily there will be a lot of labor room pollution with nitrous oxide. So that is the idea of going in for demand flow anesthesia. Entonox machine is required. Okay, so what are the advantages of using Entonox?
It's easy to administer. It's a non-invasive way to provide labor anesthesia.
First stage, it is most very effective in the first stage of labor, sir.
Okay.
And also during the delivery.
Okay, so onset of action?
Action is
30 seconds.
30 to 45 seconds.
Yeah, just 30 seconds, the onset of analgesia will be there. When, because, usually invariably the mothers will be either in stage of analgesia or stage of excitement. Only these two stages, because we know the Mach value of nitrous oxide is, what is the Mach value of nitrous oxide?
106.
Yeah, 105. So that we will not be using. Then you will have to use 100% nitrous oxide, which is, produces total hypoxia. So that is why we are using only 50%. That means it will not produce any anesthesia as such. It will produce only analgesia. So what are the drawbacks of Entonox?
It requires a special apparatus, a
Apparatus.
special machine.
The one we just now spoke about. What are the
Labor
other?
labor room pollution.
Pollution.
For
Right.
maternal satisfaction.
Yeah, the patient should be able to anticipate and take breaths accordingly when she's having pain 30 seconds and before, because otherwise then she will not have proper satisfaction with the Entonox.
No, but usually they'll know, because once they go into the active phase, usually the contractions will be very regular. There are almost about 3 contractions every 10 minutes. Every 3 minutes they'll have a contraction, so that they just get used to that. That is fine, but that can be a a disadvantage. Okay, then anything else?
Parturients won't be fully satisfied with the pain relief, sir.
That is there because it may not be very effective for active phase and second stage of labor. That is always there. But the other problems are the nausea, vomiting. That can be very high incidence of nausea and vomiting. And sometimes if the mother is very sensitive, she may even lose consciousness. So that we don't want. And she may lose consciousness and even she may aspirate. So that is one of the drawbacks of Entonox. Any other inhalation anesthetic agent has been used?
Sevenox, sir, which is a sevoflurane of 0.8% with nitrous oxide.
Internals.
And we also have with isoflurane and halothane as well.
No, halothane and isoflurane are not usually used because their blood gas solubility coefficient is so high. The onset of action is very delayed. That is why we don't use them. And one more in olden days, they were using was trilene, trichloroethylene. Very good analgesic, as good analgesic as nitrous oxide. So that is what trilene was being used, and EMO was used to be used for providing analgesia, because EMO is a draw-over vaporizer. So again, only when the patient takes creates a negative pressure, air passes through the trilene and then provide the trilene to the mother, so that it is like a demand flow only. So EMO trilene apparatus, it was called as Emotril. It was being used. Okay, so these are all some of the systemic drugs that can be used for. They may not be able to provide a very satisfactory analgesia again. So the gold standard for labor analgesia definitely will be regional analgesia technique. Okay, so among regional analgesia technique, again, the epidural probably, or central axial blocks are the gold standard, especially the epidural. So now, okay, so if you have convinced the mother to have the epidural, so how do you go ahead and then give? And among the, again, central axial blocks, what are the different types you can have? One is epidural. The other things?
We have spinal as well, sir. Spinal, epidural, combined spinal epidural. In nerve blocks, we have pudendal nerve block.
Continuous spinal.
Continuous spinal.
No, always when you are asked how you should tell is epidural, combined spinal epidural, and continuous. Then you can have continuous spinal. So these are the 3 different techniques. And within each of these techniques, there is again sub-techniques are also there. And of course, paracervical block and pudendal nerve block, which are usually not used by the anesthesiologist. They are used by the obstetricians themselves. Okay, if you want to go for epidural, now how do you go ahead? When you want to start your epidural? During the active phase? During the second stage?
During active phase, after during the active phase,
When
When the
the
patient is 4 to 5 centimeters dilated, that is when the active phase starts. At the end of latent phase and when active
or
phase starts,
maternal request.
Ideal would be latent phase. Because other than maternal request, we have many of the diseases, especially hypertensive disorders of pregnancy and even cardiac disease of pregnancy, cardiac diseases in the pregnant mothers. So all these even they can get disturbed even with the latent phase, whatever the pain is there. Though the pain is not severe, but that is enough to produce tachycardia, and this tachycardia can produce a lot of problem in a patient with, say, like severe mitral stenosis, severe aortic stenosis, and even cardiomyopathy patients and all. So that is the reason ideal would be to start labor analgesia other than the maternal request to be in the latent phase. So one advantage of putting a catheter in the latent phase is what?
Patients more cooperative.
Yeah, patients will be more cooperative. And not only that, the patients are having pain, they'll be, moving. And in a patient who is not still, can you place an epidural catheter, or even identification of the epidural space itself will become so difficult. There are likely chances that you may puncture the dura, isn't it? So that is why if you place even in a mother who is want to have the labor analgesia but doesn't want the pain relief at that particular time, you can definitely place the epidural catheter and then wait for her to request. That is there. And other thing is, in any preeclamptic mother, we were talking about the prophylactic epidural. There also, as soon as the mother goes into labor, it is better to place the epidural. The other advantage with placing a prophylactic epidural is probably in a mother with thrombocytopenia. Because there is a rapid trend of decreasing platelets. So if you place an epidural catheter when the platelet count is more than 70 or 80,000, then you can definitely activate it even if the platelet count comes down later. You need not have to worry at all. Because this will be there, and you can even go for anesthesia using this, even if slight reduction in the platelet, because the lower platelet count for you to place an epidural is maybe about, ideally it's about 80,000, more than 80,000, but we place even when it is between 70 to 80,000 also we place. But if there is a trend of decrease in platelets, and if it has come down to 60,000, you will not be able to place an epidural. So that is how, when the initial part of the labor and when the mother has a higher platelet count only, it is always better. As such, it is always better to place an epidural catheter in the latent phase. So Mukhtar, you were telling in the active phase. Is there any particular reason why you said like that? Because maybe about 10, 15 years back, 10-15 years back, we were placing the epidural catheter in the active phase only, and we were activating it in the active phase. We never used to activate before the mother has gone for less than 4 centimeter dilatation. So there was a definite reason during those days. Now that reason is not there. So what was the reason that was being given during those days?
Prolongation of the latent phase, if placed in latent phase.
No, let it prolong. So what? You are providing analgesia. Now, what we were worried was accumulation of bupivacaine producing motor blockade. Because for a long time, if you keep introducing bupivacaine into the epidural space, it was thought that it may produce motor blockade. But the problem during those days was, I was telling you, we're using higher concentration of bupivacaine. And that was the reason, and not this. And later, when they switched over to adding fentanyl and lower concentration of local anesthetics, so the incidence of cesarean section, drastically came down. There was hardly any incidence of, and the incidence of cesarean section was same as in the mothers who had not been given labor epidural analgesia. So that's how there is a lot of advantages are there. So that is the reason why you can initiate your placement of a catheter. You can activate it anytime later. But in mothers with systemic disorders or with hypertensive disorders, it is better to activate early. That is always there. Okay. So now, again, placement of epidural, what kind of technique you will be using, whether it is negative pressure technique or loss of resistance technique.
Loss of resistance.
Yeah, why not negative pressure technique?
Because the epidural space no longer will have negative pressure because of the.
Hey, why there won't be any negative pressure in the epidural space in a mother? Parturient.
Because narrowing of the space with the engorgement of veins.
No, it's actually because of, I can give you a clue. So it is because of aortic caval compression. What happens in whenever parturient has aortic caval compression?
The blood takes a collateral route through the back-centrifugal plexus, and thereby causing increased pressure in the epidural.
There will be automatically there will be increased pressure in the because of the pumping action of and engorgement of these veins. So the volume of the epidural space comes down. Whenever the volume comes down, what happens to the pressure?
Pressure increases.
What is that law? Volume and pressure inversely proportional to each other when temperature is kept constant.
Temperature. Gay-Lussac's law. No, wait.
Boyle's law.
Boyle's
It is Boyle's law, isn't it? Volume and pressure relation is always Boyle's law. And pressure and temperature, it is Gay-Lussac's. Volume and temperature, it is Charles. Charles. So those relationships and the name of the law, you should always remember because very commonly asked in the exams. Okay. So there is no negative pressure in the epidural space. So that is what commonly we'll be asking you this particular question. Identification of the epidural space is usually you go for loss of resistance technique. And again, okay, we'll discuss this about the problems associated with these things when we discuss about the physiological changes of pregnancy in next short case. I'll not go into details about this. So, okay, you have placed an epidural and then what? What are the different methods you can use for when you have an epidural?
We can
intermittent boluses we can give them, or continuous or even both.
We can give continuous infusion or continuous infusion with intermittent boluses.
Okay. Can you just tell what are the advantages of each one?
Intermittent boluses, the spread is better, sir.
Yes, very good.
And analgesia is also better.
Once the more segments are involved, analgesia will be better.
Analgesia is better. And disadvantage will be the patient will develop a breakthrough pain, sir, whenever the effect comes down.
Very good, very good. So, what about infusion?
There won't be any breakthrough pain. That is an advantage of continuous infusion. And disadvantage will be the spread won't be
adequate enough to cover all these segments.
Adequate analgesia may not be there.
So the better way is to combine both, to have a continuous infusion with intermittent boluses.
Okay, so how do you go ahead?
First bolus will give 0.1 0.2% Ropivacaine of 10
What about the test dose?
We would
avoid it preferably because adrenaline
is there and preferably avoid test dose.
How do you identify whether your catheter is inside the
time we aspirate and see every time we give drugs, and while giving drugs we should not give more.
For example, now let us say that the mother is not a hypertensive mother. In hypertensive mothers, mothers with cardiac disease, you avoid adrenaline, isn't it? So otherwise, what is the problem with adrenaline as such? If you are using dose, what is the problem? Why you wanted to avoid a test dose containing adrenaline?
One thing is, sir, it is a tocolytic, sir. Adrenaline, and also it can reduce the uteroplacental circulation.
So tocolytic, how does it produce tocolysis? Adrenaline. What effect of adrenaline can produce decrease in the contractility of the uterus?
Beta 2
Yeah, beta 2 agonistic effect. So the beta 2 agonistic effect, because we give beta 2 agonists, salbutamol, terbinafine inhalations for many of these mothers, isn't it, to produce if they develop early labor or premature labor. So that's how the beta 2 effect of adrenaline can produce relaxation of the uterus. One, okay. What are the other? Second, as Mukhtar was talking about, it can also reduce the uteroplacental circulation. Fine, by vas alpha effect, vasoconstriction. Okay, then anything else? Now, one more thing you see.
Along
No,
with lidocaine, if you use it.
Yeah, lidocaine, yes, 2% lidocaine can produce sometimes because of high concentration, it can produce motor blockade. That is not because of the adrenaline, that is because of the 2% lidocaine.
We can prefer to give 1.5% in such case.
Pardon?
We can prefer to give 1.5% lidocaine in such case.
1.5% also can produce. That is what we'll come to that. Why 1.5%? Why not 2% test dose at all? That is there. But again, adrenaline, again, because you want to look for the increase in heart rate for more than 10 beats per minute, isn't it? That is what you will be looking for if it is placed intravascularly, inadvertently placed intravascularly. So, but if the mother develops a pain during that particular time,
Be able to assess.
You don't know whether it is due to the pain the mother is having, increase in heart rate, or whether your catheter tip was there inside the intravascular compartment. So that is another drawback whenever you want to have a lidocaine with adrenaline. And again, you said lidocaine, you don't use 2%, you want to use 1.5% in all maternal epidurals as a test dose. So why 1.5%? Why not 2%?
I thought for motor blockade only.
No. For example, now I want to put an epidural for anesthesia. I would be using. No, why 2? Because, lidocaine, what you are actually testing for?
For intrathecal placement.
Intrathecal placement means what you will be checking for?
Motor blockade.
Motor blockade. So for producing motor blockade, it should have enough quantity to be introduced into the intrathecal space, isn't it? So the minimum quantity, the mass of the drug in non-pregnant mothers or patients is 60 milligrams. Pregnancy, there is a decrease in the requirement by almost about 30%. Yes. That is why 45 milligrams is enough to produce spinal anesthesia. Spinal anesthesia means motor blockade, and 45 milligrams is enough. You need not have to give 60 milligrams, because 60 milligrams in occasional mothers can even produce total spinal. That is why you don't want to use that 2%. You always go for 1.5%. But here we are using 2% lidocaine with adrenaline, because 1.5% is not available with 1 in 2 lakhs adrenaline. That is always there. But anyway, for labor analgesia, why you don't want, one is you said motor blockade, other problems with adrenaline. Is there any other reason why you don't require as such? You don't require to go for a test dosing for labor analgesia. Because, the concentration of the drug or local anesthetic, what you use is such a small concentration. Even if you are using 10 ml of 0.1% or 0.0625%, you are giving just 10 milligrams or 6.25 milligrams of bupivacaine. And even if it directly enters intravascularly, it is not going to produce any problems like local anesthetic systemic toxicity. That is a very small drug to produce any kind of even neurotoxicity or cardiac toxicity in the mother. That is why there is no point in using local anesthetic, test dose. One. The second thing is, if it is your inadvertently your catheter tip is in the intrathecal space, And this dose is enough to produce motor blockade. So immediately you will come to know. It is not going to produce total spinal. Because, 10 milligrams, usually 10 milligrams of bupivacaine you will be using for spinal, isn't it? In pregnant mothers. Majority of the times. It is 10 milligrams is more than sufficient to produce good spinal anesthesia. And that is what you will be injecting in the beginning, 10 ml of 0.1%. If at all, you can immediately recognize if there is any interthecal placement and motor blockade. So that is the reason why they say that there is no requirement of test dosing. But when you're not using test dose, you should take some precautions. What are the precautions you'll be taking?
We have to aspirate every time before giving the drug, every time for the entirety of the full labor anesthesia and anesthesia.
Right.
And also,
But do not give the full volume.
we have to give in divided doses.
The 5 ml, not more than 5 ml. Okay. Then anything else? You be in contact with the mother every time you are giving a top-up. Continuous contact with the mother is very important, because then you know any altered sensorium is occurring. Then immediately you will recognize. A very sensitive mother can develop local anesthetic systemic toxicity even with this drug dose, so that you can immediately know about, isn't it? So with these precautions, definitely you can avoid a local anesthetic systemic toxicity. So labor analgesia, you don't require to use a test dose. Okay. Now, how do you go ahead? Now you don't want to use a test dose. Okay. Now, what is the first dose you are telling about?
We prefer to give ropivacaine, because that is the drug we give in our institute, and it is less cardiotoxic than bupivacaine.
Because less cardiotoxic, fine, that is okay. But what is the drawback of the advantage of ropivacaine again, other than cardiotoxicity?
Duration of motor blockade will be less.
Duration of motor blockade will be lesser in comparison to bupivacaine.
It won't produce motor blockade because it's less lipophilic when compared to bupivacaine and levobupivacaine. Because it's decreased lipophilicity, it won't produce any motor blockade. So that is another advantage with ropivacaine. That's why ropivacaine is gaining a lot of popularity for labor analgesia and not for anesthesia. Okay, you want to use, what is the percentage you want to use initially?
0.2% ropivacaine, 10 to 12 ml, with 2 mics per ml of fentanyl.
Okay, fine. So subsequently, how long this will be effective? The first
1 to 1.5 hours, sir.
Yeah, 1 to 1.5 hours. Very good. So subsequently, go for
0.1% ropivacaine, 10 to 12 ml with or we can give, yes, sir. Or if you have to give as an infusion, 0.1% ropivacaine, 8 to 10 ml with intermittent borosine.
Every hour?
Yes, sir.
Per hour infusion. Yes. So that is one of the methods definitely you can follow. That is there. And any other precautions you'll be taking whenever you want to give top-ups? Anything to do with your position of the mother?
We have to make sure, depending on the stage of labor, we'd like to position accordingly. If the patient is in second stage of labor, we'd like to patient to be in more of a reverse Trendelenburg position or a sitting position, so that the sacral spread is more. Therefore, the analgesia is better for the second stage. Whereas in the first stage of labor, since the catheter is placed in around L2 to L3, we can just keep them in supine, and we can have adequate analgesia. Congruency of the catheter can be good.
That is what, every time you want to give a top-up, so it is better to elevate the upper torso of the mother by 10 to 15 degrees. So by the time she reaches the second stage, she is almost, vertically or sitting almost. So that, you can make sure that the sacral fibers, because you don't want the analgesia to go up. Above L1, T10, you don't want it. So you want it at least by gravity, it will be coming down and it will be producing better analgesia of the sacral fibers as the labor progresses. So this is another very important precaution you have to take. Okay. So what are the other techniques you want to go for? one is combined spinal epidural also we said.
Dura puncture epidural is there.
So combined spinal epidural or dural puncture epidural. Okay, what is the advantage of, how do you go for dural puncture epidural?
We will, while securing the epidural, we will puncture the dura but not give any drug into it. And then after that, we will secure the catheter in the epidural space. So
What
the advantage,
needle you will be using? Any special needle for this dural puncture epidural?
27 gauge.
No. Any special type of total set you get?
Splitting needle. Splitting
It is
needle of
through needle technique, isn't it? Single segment needle through needle technique. So you first identify the epidural space using your epidural needle of 18 gauge. Then through that, you'll have to pass the spinal needle, a pencil point 27 or 29 gauge needle, it will be there. So it pierces the dura, and then once CSF comes out, you inject, either you inject or you don't inject. So depending on whether you are going in for only dural puncture epidural or you all want to go for combined spinal epidural. So that is always there. So what is the advantage of using a needle through needle technique?
we can be very sure that that is the epidural space, because we'll have a confirmation that the subarachnoid space, we'll get the CSF. So we will know that that we have secured it in an epidural space, as opposed to, because the epidural will be quite difficult in a parturient as opposed to a normal person. So that is one advantage. And second is the quality of analgesia is better because some of the drug is passes to the intrathecal space. So the onset is slightly quicker, not as quick as combined spinal epidural, but
You're talking about dural puncture epidural. That is there.
yes.
And another very important thing is when you are placing an epidural catheter in a separate segment or separate interspinous space, the epidural needle may not be in the midline in the posterior aspect. It may slightly deviate on one side, still you will identify the epidural space.
Yes.
It may be tangential to the dura, but still you will identify when you pass the catheter will go only to one side.
Yes, sir.
But what we want is the needle to be exactly in the midline and the posterior aspect. Yes. So that, it will be there in the midline so that it can easily produce analgesia on either side. So when you are using a needle through needle technique, if your epidural needle is slightly on the side, you will not be able to pierce the dura with your spinal needle. So if you can pierce the dura with your spinal needle and if you can get the CSF back, you are 100% sure that your epidural needle is in the midline and the posterior aspect. That's how the success rate of your epidural will be very high. So that is always there. So that's how, needle through needle technique is an ideal type of needle you can use for the combined spinal epidural or dural puncture epidural. Okay, the combined spinal epidural, how do you go ahead? There are a lot of advantages of combined spinal epidural are there.
So in combined spinal epidural, we will the same technique, but in the intrathecal space, we will give around 2.5 mg of bupivacaine, and then after that we can secure the epidural. This is the advantage.
Any fentanyl?
Yes, sir. We can local anesthetic. Local anesthetic with fentanyl we can give, sir.
Fentanyl 25 micrograms or 50 grams. Or many
or
times
only opioid.
You can use only fentanyl intrathecal. That is the latent phase, isn't it? And you can allow the mother to walk around also. The walking epidural also you can have with that only. Or you can use just 2.5 milligrams, like half cc of bupivacaine heavy. Here you are using heavy and half cc of fentanyl. So total it will be 1 cc intrathecally. So this is going to produce rapid analgesia within 5 minutes, and the analgesia can continue for almost 2 to 3 hours many times. And many times you don't require to activate your epidural, and the mother can deliver with this analgesia only. So a lot of advantages with spinal epidural is there. But what are the disadvantages with CSE technique? Any disadvantage with CSE technique? You are puncturing the dura.
Increased incidence of PDPH.
Yeah, one is increased incidence of PDPH. And another thing, you are using this technique in the labor room. Any problem?
We cannot. This patient has to be shifted to an operation theater to be done. We cannot do this in a labor room due to its sterility concerns.
Yeah, that is always there. Infection problem is there. So these two are the concerns when you are using a combined spinal epidural. One is infection, meningitis, encephalitis, or even epidural abscess. And second thing is, as you are talking about these PDPA, though that is why the combined spinal epidural needles, that needle through needles are ideal because you'll be using a pencil point needle there, and the needle size also is either 27 or 29 gauge needle. And that needle will be directly going through the epidural needle. So
Yes.
that needle is not touching the skin. Another advantage of preventing any infections carried directly into the interthecal space. So there are a lot of advantages with needle through needle technique. So ideally you can use that. Okay, so these are some of this thing. And any advanced techniques using this combined spinal epidural? Any something advanced in labor analgesia, which has been
Computer integrated this thing.
correct. Computer integrated continuous
Analgesia.
epidural analgesia. So computer integrated parturient controlled epidural analgesia. It is computer controlled parturient
Controlled.
integrated. Actually, it is computer integrated parturient controlled epidural analgesia, CI, PCEA. That is what it was tried in Singapore, and it's quite popular there. One more technique.
Computer integrated intermittent bolus.
Yeah, programmed intermittent bolus, epidural bolus technique. Programmed intermittent epidural bolus, PIEB techniques. So these are also quite popular. What is this programmed intermittent epidural boluses?
So we keep a set timer, sir, and after every timer, one bolus, instead of a person going and giving a dose, the machine itself will give a dose according to whatever time we set.
No need of
we don't
activate the epidurals, right?
No, we don't.
Every 30 minutes itself delivers.
It delivers the drug.
Every 30 minutes, how much? What is the dose?
That is 0.0625.
No, that is okay. That is the drug you give. What is the dose?
8 to 10 ml.
5 ml. Every half an hour 5 ml, so that 1 hour 10 ml. That is what 1 hour 10 ml you would have given boluses. So instead of we giving manual boluses, the computer itself will be programmed in such a way that it keeps injecting every half an hour 5 ml, so that the breakthrough pain will be avoided. Because every half an hour, and what about programmed intermittent? Not this. So computer integrated parturient controlled epidural.
The patient will request for the analgesia, and the computer will. It's like PCA, sir. But after every request, the infusion rate is increased by the computer.
Correct. Because if she is requesting early, within 1 hour, if she activates it second time, first time when she activates, the infusion starts at 5 ml. Suppose if she activates another time within 1 hour, so that means computer thinks that she requires more infusion. So higher infusion rate. So it increases to 10 ml. So if she activates the third time within 1 hour, it increases the infusion to 15 ml. So if she activates fourth time within 1 hour, what happens?
There will be an alarm, this thing, sir.
Yes, very good. So that your epidural catheter is not properly placed. Because request so many times the epidural boluses, isn't it? Within 1 hour, fourth time. So you'll have to resite the epidural catheter. So that is always there. So that is also some of the newer advances as far as epidural analgesia is concerned. And one more, you only mentioned about walking epidural. So what is this walking epidurals?
Give a reduced dosage of local anesthetic with opioids so that we can help ambulate the patients. So as opposed to 0.125 or bupivacaine, we can give 0.0625% of bupivacaine or 0.1% of bupivacaine. And then we give the bolus, and then after that we test for motor blockade. We have some couple of tests where we ask the patient to raise.
Though we call it as walking epidural, it is more of a combined spinal epidural. you always go for a combined spinal epidural, whereas you would have injected intrathecally either only opioids or very low dose your bupivacaine, and it is usually done in the first stage to hasten the first stage of labor, and so that the descent can be faster. So that is what you do. It can be done with epidural as you are talking about, but most of the time, 90% of the times, walking epidural means it is always a combined spinal epidural. Okay, how do you check for the motor blockade, sensory blockade, and the postural hypotension?
First, we will check. We will ask the patient to raise the leg, or we'll ask the patient to bring the leg to the knee, so as to flex the leg. So to see motor blockade, we will also check if the patient's feet is patient is having sensation over the feet, and then also we have to check for orthostatic hypotension. So when patient stands up, we have to check for drop in blood pressure.
First, you make mother to sit and then check blood pressure. You don't immediately make the mother to stand. First, as you said, that straight leg raising test you do. So the mother should be able to elevate her leg straight without flexing at the knee joint. So that is for motor blockade. And again, you check for the sole, actually, not the foot itself. The sole should have absolute sensation. Otherwise, when she walks, if she doesn't have sensation, she is going to fall. So that is second thing you will check when mother is lying down only, and make the mother to sit on the cot with her legs dangling on the side of the cot. Now you check for the blood pressure. There should not be much fall of blood pressure, not more than 15 or 20 millimeters of systolic blood pressure. Then you make the mother to stand with the support of the cot.
There should be always a person who accompanies the mother while walking.
No. Before walking, I am talking.
Okay.
To make the mother to stand with the support of the cot. So she can leave the cot and then she stands. And again, you check for the blood pressure in the standing. So you want to 100% make sure that there is absolutely no, postural hypotension. So that you do. And then you make her to do a half deep knee bend test. So she has to, bend her knees, half bend her knees and stand in that posture, to know the motor power of the quadriceps. So that has to be present. She should be able to stand with half deep knee bend. So after making sure, then you can make her walk along with her husband. So husband is the best person so that he will increase her pain threshold also once he is there with her. So that is the best method. So she can walk around and then, her, the pain will come down because, the distraction she will have, because she'll be looking around, and so she'll also have a distraction. Because of that, her pain threshold will come down. Though what has been seen is it may not actually hasten the progress of the labor. Maternal satisfaction was very high with it. So that's how, walking epidural is also another thing which has been practiced. So one more, thing is about the continuous spinal. When do you go for continuous spinal?
Inadvertent catheterization into the spinal space.
Inadvertent dural puncture, one indication. Okay, what are the other indications for continuous spine?
Difficult
epidural placement.
spine, difficult.
If spine is difficult, spine is there. Then also you go for it. Okay, anything else?
Obese patients, difficult spine, obese.
Yeah, no, obese patients. Again, difficult spine can be, scoliosis, kyphosis, all those things. And morbidly obese patient, again, by putting a catheter intrathecally is easy than identifying the epidural space. Then anywhere, any patient.
Patients with previous spine surgeries.
Yes, again, patients with spine surgery. Yeah, correct. You go for continuous spinal because epidural space may not be properly there. There can be total fibrosis of the epidural space. Okay, then anyway, anything else is the indication? In patients with severe aortic stenosis, severe cardiac disease, especially aortic stenosis where you don't want to produce any sympathetic block. So you can give only intrathecally opioids. by using a continuous spinal catheter. So that is another indication for continuous spinal. Okay, so you are placed and inadvertently you are punctured or any other indications were there. So you have catheterized the spinal, intrathecally you have put the catheter. So now what is the dose you will be using?
0.1% local anesthetic 2 ml with
Ropivacaine, you mean?
sir?
Ropivacaine, 0.1% ropivacaine.
Ropivacaine 2 ml with 2 mics per ml fentanyl, sir.
Okay, that is intermittent boluses. One every hourly, you can give 2 to 3 ml of this. Fine. Is it isobaric one or hyperbaric one you will be using?
Hyperbaric.
No, not hyperbaric, isobaric only. Because it will go down if you are using hyperbaric. That is small quantity. So you want T10L1 block, isn't it? So you use isobaric drug only. For labor analgesia, it is always isobaric. You don't go for hyperbaric. All isobaric. And we have also found that hyperbaric continuous infusion lidocaine had produced Cauda-Equina syndrome. That is why it went into disrepute. So initially almost 6 mothers developed Cauda-Equina syndrome with continuous spinal with microcatheters. So that's how we don't use it nowadays much. But you can still use it, the macrocatheter also, if you have an inadvertent dural puncture, or pediatric epidural catheters, 24 gauge has been used. They are available and they can be used for continuous spinal. So suppose, and then if you want to go for infusion?
Infusion we give 0.625% local anesthetic, sir, with again 2 mics per ml fentanyl, 3 ml per hour.
You are planning for bupivacaine because initially you gave ropivacaine. Why do you want to change? You can still use the same ropivacaine 0.1% with 2 mics of fentanyl. So 2 to 3 ml per hour. Same boluses and this thing is same. Like epidural 8 to 10 ml you are using. Here just 2 to 3 ml. So you just gave. So that is what. So of course, the one complication is always PDPH. Always you can expect. And you should be ready to manage PDPH. That is already we have discussed in detail about PDPH before. Okay, so that is another continuous spinal analgesia also you can use. So these are the different techniques. And one, sometimes you may be asked, suppose if epidural you have placed and it has become patchy, how do you manage this problem? Either it can be patchy or it is not acting at all. These two are the problems with your epidurals.
We can pull the catheter out a little to see if it's inadvertently gone into another space.
So before that, can you do something else? Suppose it is acting only on the left side and not on the right side.
You can tilt the patient.
Because most of the time you will be keeping the mother in the left lateral, isn't it? So that's how it may become patchy. So you can turn the mother to the right lateral and inject another 8 to 10 ml, wait for about 3 to 5 minutes, and then you can check. So that may become, bilaterally, it may be effective. That is one thing. Or your catheter may be slightly, it has moved inside. So as you said that you always can pull out by 1 centimeter and then re-inject the drug. So that is how you can make up this particular problem. And suppose if it is not effective, then what you do?
Reinsert.
Better to think that your epidural is not properly placed and it is better to take it out and then definitely resite. That is always there. Now, these are things about the labor analgesia. Any other questions regarding the labor analgesia? Because these are the likely questions you may be asked in the exam, in the practicals. Any particular doubts you have regarding the labor analgesia?
Converting to anesthesia.
That will come with the next part.
Discuss, definitely. We'll discuss in anesthesia part. That is correct. We'll be discussing that in anesthesia part. How do you convert labor analgesia into anesthesia?
Sir, there are some places where we can, instead of giving a test dose lignocaine, some places they say that you can give fentanyl as a test dose.
No, that is for not for labor analgesia when you are going in for anesthesia. Like,
Okay,
for
sir.
example, now for this mother, if you want to place an epidural and you want to go for test dosing, then definitely you don't want to give, adrenaline containing solutions, or any mother with mitral stenosis or aortic stenosis or any cardiac disease. So definitely you can give, first you can give, instead of lidocaine with adrenaline, you first give 100 micrograms of fentanyl just to rule out intravascular placement. If your catheter is intravascularly placed, immediately the mother, because directly 100 micrograms injected fentanyl will produce some amount of sedation.
Yes, sir.
Suddenly the mother will be very much sedated. Though it may not produce any harm, but it can produce quite a bit of sedation to the mother. Then you know that if it was in the epidural space, it will not produce any sedation.
Okay, sir.
That's how you can know whether your epidural catheter is in intravascular or not. So the other methods are also there to know in such patients where you don't want to use adrenaline, especially in these hypertensive disorders of pregnancy. Is one more thing is you can use phenylephrine. So you can give 25 micrograms of phenylephrine, and then immediately you check for blood pressure. If there is any increase in more than 10 millimeters of mercury of blood pressure increase, then you know that it may be intravascular. So the other methods are you can inject 0.25% bupivacaine 5 ml intrathecally.
Okay.
So and then check for the mother, has she developed immediately any circumoral numbness or any metallic taste? That is, if it is intravascular, it will not produce convulsions or anything. This is about 12.5 milligrams. It can produce some change, especially the circumoral numbness or metallic taste. So that is one of the methods. Or if you have a precordial Doppler, so the same fetal Doppler, you can convert it into a precordial Doppler. You take out from the abdomen, you keep it over the precordium of the mother and inject half to 1 cc of air rapidly through the epidural catheter. But make sure that she doesn't have any left to right or right to left shunts in the heart. So you can inject 0.5 to 1 ml rapidly. And if there is any change in the note of the precordial Doppler, because it is only qualitative, it won't say how much air has been injected, but it says that air is inside the vascular compartment or it has entered into the heart. So that way, these are some of the tests. Sometimes you may be asked to tell about the other tests, test dosing other than the lidocaine with adrenaline. So just remember about these things. You can use fentanyl, you can use phenylephrine, because again, phenylephrine, why you select phenylephrine, especially in patients with mitral stenosis or aortic stenosis, where you don't want to any increase in heart rate, because phenylephrine, even if it enters into the blood, it is going to decrease the heart rate. That way it is fine. And even if it is intravascular and in a mother with a hypertensive disorder, the increase in blood pressure is not so much. So still you can use 25 micrograms, not more than 25 micrograms you can use. Okay, the other than that is, 0.25 5 ml bupivacaine or air. So these are 1, 2, 3, 4, 5 methods you can just remember to avoid adrenaline producing problems. Okay. Now let us discuss about anesthesia for preeclamptic patients. So, okay, if a preeclamptic mother is there without any contraindication for neuraxial blocks, like what are the contraindications for neuraxial blocks in a mother with preeclampsia?
Decrease the platelets, thrombocytopenia, very
Coagulopathy. You can just say coagulopathy. Coagulopathy can include DIC or it can also include thrombocytopenia. Okay, so any coagulopathy is absolute contraindication, right?
Infection at the site of spinal or epidural.
For that, mother refusal.
Maternal refusal for
the most important contraindication for regional anesthesia. Anything else? like, for example, now there is a category 1 indication for cesarean section. There is no
Yes.
time, because if you want to go for regional anesthesia, at least you should have sufficient time, isn't
Yes.
it? Even for spinal, you require 15 minutes. For epidural, you require nearly half an hour.
Yes.
That time has to be there. Suppose if it is a category 1, what is category 1?
Needs to be delivered immediately.
No.
Like
There is a
fetal distress.
life-threatening for either the mother or the fetus. If you don't deliver immediately, either the mother's life is at stake, or even the fetus may die. So that is category 1. So in such situations, many times you may not be able to go for regional anesthesia, you'll go for general anesthesia. So these are some of the contraindication for regional anesthesia or central neuraxial block techniques. Okay, suppose if there are no contraindication, so what is the technique you can use?
If there is epidural catheter in place,
We can
then we
activate.
can go.
That we will come to it later. Elective cesarean in a mother with preeclampsia.
Okay, sir. We can provide regional anesthesia with spinal anesthesia.
Yeah, spinal is okay in a patient with hypertension.
Hypotension.
Hypertension.
Yeah, it is good, sir, because it will reduce the SVR and also it will increase the uteroplacental.
No. You talk about spinal anesthesia, where the sympathetic blockade can be very fast, very rapid.
Okay,
Not, I'm not talking about graded epidural.
okay.
But you said spinal anesthesia, isn't
Yes,
it?
sir.
So
Such
why?
cases we can also give prophylactic vasopressor support while giving spinal to avoid the drastic drop of.
That is different. You just tell me what are the advantages of spinal anesthesia. Will there be?
We will not manipulate the airway, sir. The airway is very difficult in such cases.
That is
So,
same with all kind of regional anesthesia.
okay,
Manipulating the airway. But why spinal? Because we were scared to give spinal in olden days, because rapid onset of sympathetic block can produce a crashing of the blood pressure. So we
okay,
may not be able to control the blood pressure. That was what we were thinking. So what was the studies later proved with spinal anesthesia and hypotension in a preeclamptic mother? Now they found that the amount of hypotension that occurred was less than when spinal anesthesia was given for normotensive mothers. In normotensive mothers, there was more incidence of severe hypotension compared to the hypotension incidence in preeclamptic mothers. So what was the reason that has been attributed later? Why less incidence of severe hypotension after spinal anesthesia in preeclamptic mothers, where you expected a crash of blood pressure? Now, what is the reason for hypotension?
because of the peripheral pooling of blood and peripheral vasodilatation.
Sympathetic block, isn't it?
Sympathetic blockade, yes, sir.
Fibers block. When you give spinal anesthesia, which sympathetic fibers get blocked?
A fibers.
No, I'm not talking ABCD. Which fibers actually? From, sympathetic has got, from the spinal cord, sympathetic fibers originate T1 to L2.
Yes, sir.
Then they'll come to the ganglion, they relay in the ganglion, the postganglionic fibers, long postganglionic fibers will reach the vessels, and they'll be supplying these vessels. So which part of this different sympathetic system gets blocked first? Is it preganglionic fibers, the postganglionic fibers? It is always the preganglionic B fibers which get blocked as soon as you give spinal anesthesia, because they are thin fibers, they are myelinated fibers, because C fibers take a longer time to get blocked. it is always the B fibers, which are myelinated and thin fibers, they get blocked. They are preganglionic efferents going from the spinal cord to the ganglia. And once they get blocked, there is a further blockade of the postganglionic fibers also. Because it has been blocked before the ganglion. So postganglionic release of noradrenaline will not be there at the neuromuscular junction of the smooth muscle and the autonomic nerve ending. So that is the reason why vessels will dilate, and that produces hypotension. But why there is no, even though there is a preganglionic afferents are blocked in a preeclamptic mothers, why they don't have hypotension? It is because, in these preeclamptic mothers, the circulating vasoactive substances are so high. And because of this, the effect on the, angiotensin 2 receptors by the circulating vasoactive substances is so high, they almost, you can say the sympathetic blockage is not much effective in producing vasodilatation. Still, the vessels are partially vasoconstricted only. That is the reason why these mothers, they found out that the incidence of severe hypotension is much less when you give spinal anesthesia. That is why, simple technique, spinal is very simple technique, isn't it? And success rate is very high. In these mothers, you don't want to fail. If you fail, you will have to go for GA, and GA, it's so difficult to go for GA. So that is another reason, another advantage with spinal anesthesia itself. That's why probably for your patient, what you have found, you would have given spinal only.
Yes, sir.
So the other techniques are, people who are scared about giving spinal, they can always give a graded epidural. So how do you go for graded epidural? How do you give this graded epidural?
We give once after securing the epidural, sir, we start by giving the boluses, but not more than 5 ml at any particular time, and we have to wait.
For graded epidural, would you like to give a test dose, or you don't want to give a test dose? Now, because whenever you want to go for here epidural, you will be using a higher concentration, larger volumes. When you are using labor analgesia, you are using though 10 ml, but it was very low concentration. So no problem in local anesthetic systemic toxicity will not occur. But when you are using anesthesia, you are using 0.5% bupivacaine or 2% lidocaine probably will be using. So here, actually, you should first test.
Okay, sir.
Always a test dose. So you always use either 2% or 1.5% lidocaine, 3 ml. That is for to, rule out intrathecal placement. And next thing is, if adrenaline is contraindicated, then already we just discussed.
Yes.
The other you can always try. So 3 ml test dosing is very important. Second thing is, you would be calculating what is the total dose.
Hello, sir.
Net problem was there. Okay.
Nice.
How do
Yes,
you
sir, back again.
How do you calculate for the epidural anesthesia total dose?
We calculate the number of segments, sir, and we provide 1 ml per segment. But in pregnant, it reduced by 30%.
That is for 150 centimeter height of the mother. For every 5 centimeter increase from 150 centimeter, you keep on adding 0.1 ml per segment.
That is fine.
All, isn't it? So that is what we had discussed when we discussed height and then your anesthesia, isn't it? So, and you minus 30% from this. Total dose you calculate minus 30. Let us say you require 13 ml for this mother.
Okay, sir.
You calculated. I'm just giving you an example. 13 ml. So how do you go ahead now?
After test dosing and confirming that it is in the epidural space,
we will give 2 ml of 2% lidocaine you have given. Yes. Okay, right. Then
After that, we will give 5 ml increments.
of
And
what? Is it
of
lidocaine?
lignocaine is better, sir, because we need immediate action. So 2% lignocaine adrenaline is better than bupivacaine. So we will give.
That's what you want, faster onset. Epidural, even with lidocaine, it may take almost about 10 minutes. With bupivacaine, it may take 15 to 20 minutes, soaking time. Why lidocaine, it is faster?
Because it is PK is more close to the pH.
Yeah, PK is, what is the PK of lidocaine?
7.9.
7.8. What is the PK of bupivacaine?
8.4, 8.2.
8.1. You are increasing by 0.1 for both. It is 7.8 and 8.1. Okay, so that is why you can use definitely lidocaine. But what will be the duration of action of lidocaine plain if you are using?
It will be just half an hour.
Yeah, just about 30 minutes, isn't it? So that is one problem with bupivacaine, with lidocaine. So instead of that, definitely you can even go for bupivacaine also. So because elective section, you have got a lot of time.
Yes, sir.
So either bupivacaine or ropivacaine or levobupivacaine, definitely you can go for. So if it is an elective section, so 2%, 0.5% bupivacaine also you can go.
Yes,
So now what is the total? Already you have given 3 ml, isn't it?
yes,
Plus dosing already, that also to be included here.
yes.
So now you give another 5 ml you want to give. Test dosing you would have given in lateral posture or sitting posture, in whatever the posture you had kept the mother for your epidural.
Yes,
Isn't it? You give in the sitting posture or lateral posture?
lateral is better.
Yeah, no. It all depends on your use, how you practice. So in JSS Medical College, they always give in sitting posture. So that is how you practice and your convenience. That is always there. Okay, lateral posture, you have given test dosing before you fix it. Then only you have to give the test dose and then afterwards confirming that it is not intrathecal and not intravascular. Now you fix it, turn the mother to supine posture with the wedge underneath the right buttock about 15-degree tilt, 10 centimeter wedge you have kept. Now you want to give 5 ml first. And how long you want to wait?
We wait for 5 minutes, sir. 5 to 10 minutes, and then we have to assess for the level of blockade, and then give other extra 5 ml increments until we reach a segment of T-pose.
Total, I said 13 ml you require.
Yes, sir.
But only 2 doses you can give, and maybe even less than 2 doses of 5 ml requirement, isn't it? So once you check for the upper level of the block, then you know what is the remaining segments to be blocked, and you know how much to be given. So that's how you can always give. So it is an approximate way of calculating. So it may differ in parturient to parturient. That is always there. So that's how you give an epidural. Graded epidural is always better in these mothers with the preeclampsia, so that you can reduce the problem of hypotension as such. Okay, if you're planning for a combined spinal epidural, how do you go?
We will give we can give a full normal spinal dosage and then keep the epidural in the event that the duration of the surgery prolongs or for post-op analgesia.
So normal spinal dose means based on again height.
Based on the height, we can give either 1.4, 1.8 or 2.2 ml depending on the height of 2.4 ml depending on the height of the patient.
Okay. So will there be any Eve effect?
Sir?
Eve effect, EVE, epidural volume expansion effect. Because you also
yes, sir. Because of giving the epidural volume, we have to reduce the dosage of the spinal volume.
You said that you will be giving the same dose. No, you don't reduce the dose because you don't want to have any patchy block or inadequate block. You would like to give the same dose and keep the epidural. If required, you can activate it. Yes. So what is something called as sequential combined spinal epidural? And that is majority of the times in patients with, say, heart diseases like MS or AS, you would be going for a sequential combined spinal epidural. What is the other nomenclature for sequential combined spinal epidural? Other name is low-dose-spinal with graded epidural. Low-dose-spinal with graded epidural is also called as a sequential combined spinal epidural. So you give 1 ml of bupivacaine heavy.
Okay.
Intrathecally, and after that, make the patient in supine posture and then check the level of block. Many times the level will be above T10. And if required, you can activate the epidural, or you need not have to activate the epidural. So, because many times just above T10 may be sufficient and with slight discomfort for the mother, but many of the, they have taken afterwards the questionnaire they have given to the mothers, and majority of the mothers have been said that they were very comfortable, and because they could, participate in the labor or, delivery of the fetus. Slight discomfort, they did not develop any increase in heart rate or anything. So that way, not much of sympathetic block, because 1 ml you would have given intrathecally, and it is quite ideal for patients with cardiac diseases like aortic stenosis or mitral stenosis. If required, if mother has any more discomfort, you can always add, your epidural is always there. You can grade it up, isn't it? So this is called as low-dose spinal with epidural. So you can also use it. Okay. So these are the different methods of regional anesthesia. Suppose if there is, invariably there can be fall in blood pressure. Hypotension is very common. So how do you manage this hypotension?
In such patients with PIH, we have to be careful. I mean, we cannot give too much fluids, but we should not reduce the, we should not go for restricted fluid therapy or excess. We should have, we can give fluids, but not too much, and we can give vasopressors to counteract the hypotension, preferably phenylephrine or ephedrine, as opposed to
What is the dose of vasopressors?
phenylephrine. We can give 50 to 100 mics bolus, sir.
Do you give 50 to 100 microgram bolus in a preeclamptic mother?
25, sir. 25.
You have to reduce the bolus doses. Why should you reduce?
It will
increase sensitivity towards vasopressors.
There is always an increased sensitivity to vasopressors. So if you give the regular dose like you give in non-hypertensive mothers, that can be shooting up of blood pressure. So don't go for 50 to 100, you go for 25 micrograms increments. Your maximum 50 micrograms, it's more than sufficient, phenylephrine. Suppose if you're using ephedrine, vasopressor you are using in your institute.
Phenylephrine, sir.
Phenylephrine. You are not using ephedrine?
Yes, sir.
We use both, sir. But
why not ephedrine? Any particular reason not going in for ephedrine?
Both. There were no, fetal acidosis was a concern, but now that they found that it is not that it won't cause.
Why fetal acidosis with ephedrine? What was the reason that has been given of fetal acidosis with ephedrine and not with phenylephrine? So ephedrine, what is the difference between phenylephrine and ephedrine?
Phenylephrine is acting only on, it's a preferential action on alpha 1.
It's a direct acting alpha agonist, isn't it?
Yes.
It's a direct acting alpha agonist. What about ephedrine? Is it direct acting or indirect acting?
Directly, indirectly.
It is an indirect. On what receptors it will be acting?
Oh, that's-
Ephedrine. So these are usually kept in your drug tray also in the afternoon.
yes, sir.
They'll be asking about the differences between phenylephrine and ephedrine.
Yes, sir. It will act on both alpha and beta, sir, because it releases norepinephrine.
Yeah, that is the difference. It is an indirect acting one, and second thing is it will act on both alpha and beta receptors. So does these drugs cross the placenta?
Ephedrine
Ephedrine?
crosses the placenta.
Both will
Both process. Both process.
cross. But the beta effect of ephedrine increases the metabolic rate in the fetus.
Yes.
Because when you are giving, the fetus already will be having a decreased amount of perfusion because of hypotension of the mother. There is a decreased perfusion for the baby. So that is the reason why you are using a vasopressor. So
Yes.
when you use this, so the beta effect of the ephedrine produces increased metabolic rate. Now, when increased metabolic rate and decreased oxygen supply. So invariably, the baby can go for fetal acidosis. That is what lactic acid production and fetal acidosis. So umbilical cord blood, they have found out that there is some amount of fetal pH on the lower side. Now, but you said that both can be used. Why? This reason also you said fetal acidosis with ephedrine. But afterwards you made a statement that no, sir, both can be used, no problem. Because they did not find any difference in the Apgar score.
Okay, sir. Yes.
Ephedrine or phenylephrine. That is only when they did a ABG of the umbilical cord blood. Then only they realized there is a slight decrease in the pH in mothers where ephedrine has been given. Otherwise, there was no difference in Apgar. So since there was no difference in Apgar, there was hardly any difference in giving either ephedrine or phenylephrine. What is the advantage of ephedrine over phenylephrine?
Phenylephrine does not cause, it does not increase the cardiac output much, sir. In such cases,
But indirectly, it will increase the cardiac output because the alpha effect produces venoconstriction, increases the preload. Once the preload is increased, definitely cardiac output will increase. Indirectly, it will increase, though it doesn't have any beta effect. What is the advantage with ephedrine? Now, whenever only alpha agonist is used, the phenylephrine, what happens to the afterload for the heart?
afterload increases, sir.
So now suddenly if the afterload increases, the heart may not be able to pump against this increased afterload. So though the venous return increases, but still the cardiac output may not be increased so much. That is what theoretical possibility. But when you're using ephedrine has got a beta-1 agonistic activity, increases the inotrope and chronotrope effect on the heart. So that's how it can counteract the sudden increase in the vascular resistance.
Okay, sir.
So these are the things about the regional anesthesia for. One more thing is conversion. You were asking. For example, it's a functional epidural is there for labor analgesia, or you have placed a prophylactic epidural catheter. Now they want to take up for cesarean section. How do you convert?
We can give the epidural test dose, and bolusing can be started to be given in the labor.
No, there will be the obstetrician will be in a hurry, isn't it?
Yes, sir. So we can give the bolusing in the labor room. We can start giving there itself, so that we save time while shifting to the operation theater, sir.
This is what I wanted to know. Do not give.
Okay.
This is what you should never use these things. While the patient being shifted, there can be a lot of problems. Whenever sympathetic block occurs faster, so shifting itself can produce refractory hypotension.
Okay, sir.
You'll not be monitoring also on the way.
Okay.
So it is better to avoid giving boluses in the labor room, including test dose.
Okay, sir.
And another thing is migration of the catheter can occur because of the movement.
Okay, sir.
So you might have tested it in the labor room by giving a test dose. But when you have moved the mother from the labor room to the OT, there may be, movement of this catheter either intravascularly or intrathecally. Now, if you give the regular dose, she'll have complications. So that's why don't give, even though you may be in a hurry, but don't give any drug in the labor room. Shift the mother in the left lateral position, and then you can definitely use intrauterine resuscitative maneuvers while shifting. And then only after, the mother has been shifted into the OT, you will start your test dose and know what drugs you will be using.
Lignocaine at first.
Faster onset of
2% lignocaine at
This is the time you use lidocaine. This is the time you don't go for bupivacaine. You use a test dose 3 ml and also continue with lidocaine only 5 ml increments you can use. So that's how you convert. Okay, while taking the mother to the labor room, your epidural catheter has come out.
Then directly spinal.
Yeah, because the mother had been given about 5 hours of labor analgesia. Now you have pushed so much of drug into the epidural space. Now, can you give the same dose of intrathecal?
No, sir. Lower dose, around 1.5 ml.
1.8 ml.
1.5 ml of drug. It's a lower dose.
Lower dose means, suppose if it doesn't act. No, you wanted to avoid GA.
Yes, sir.
And you want to give lower dose.
We'll give full dose itself.
If you give full dose, what is the complication you can?
Total spinal. Eve will occur and then that can cause to total spinal.
Isn't it? So total spinal is a complication. If you want to convert epidural into a spinal later, or if you want to go for a spinal with a prolonged epidural analgesia. So that is always a problem. There are case reports where total spinals have occurred. So what you should do now?
Reduce the dose.
Oh, again, reduction dose, it may not act. That possibility is always there. So
low dose,
you give the same dose, you don't change the dose, you anticipate total spinal, you keep ready, and you keep observing the mother for any kind of total spinal. So that once total spinal occurs, you are already ready, you can manage easily. Isn't it? So this possibility you should always think. This is again a common exam question, practical question. When a prolonged labor analgesia you have used and suddenly your catheter has come out and you want to go for a spinal. Immediately you will say, I'll go for spinal. But next will be, these questions will be asked. Isn't it? Now you understand the problems associated. Isn't it? Okay, so these are the different kind of regional anesthesia for cesarean section. Tomorrow we'll just go for general anesthesia for cesarean with two people only for a patient with preeclampsia, and then we go for the short case.
Okay.
What is the next short case you want to present?
Anemia.
No, that is next short case only. After that.
After that, sir, long case, liver case is remaining, sir.
Oh, you want to go for liver.
So 3 days we'll get
Okay. So day after, probably we can have the liver. So you ask somebody who is already preparing for liver to present day after tomorrow, probably. Okay. Okay. Right.
Sir, there is one doubt in the chat box, sir.
Okay.
We are giving this intrathecal opioids, no, sir. So that will cause pruritus.
Yeah.
So in such patients, should we prophylactically give phenyramine and then give opioids, or?
No, prophylactically, you don't give because it will be an unnecessary dose. Because all the patients may not develop pruritus. Intrathecal also. It is only some women may develop pruritus. For such women, you give. Otherwise, you need not have to give for all the mothers prophylactically. Diphenhydramine. Even naloxone has been tried in such women. So as in, with severe pruritus, But again, naloxone will reverse the analgesia also.
Yes.
If you use morphine, it won't reverse the analgesia because it will act only on the supraspinal receptors. Your naloxone, it will not act on the spinal receptors because morphine is hydrophilic. It will be acting only on the spinal receptors. That is why, naloxone is safe to be used even in patients who have been given intrathecal or epidural morphine. So
Okay.
diphenhydramine only if pruritus occurs, you give. Otherwise, you don't give. So one more problem that occurs when you give intrathecal opioids. What is the problem for the fetus?
Respiratory depression.
Respiratory, it is not breathing, man. It is a parasite now inside.
After,
Now, immediately it will not be delivered. It will take a long time for delivery. Fetal bradycardia. Immediately there can be fetal bradycardia. This you have to anticipate. You have to tell the obstetrician, you have to tell the mother that I'm giving a particular drug. It can produce transient fetal bradycardia. It is transient. Only for 2-3 minutes it will be there.
okay.
And if you have not, informed the obstetrician, she may think that fetal distress, non-reassuring fetal heart rate, and she may take the mother for section. So why this sudden fetal bradycardia after once you give intrathecal fentanyl or local anesthetic? Good that I asked because this is another common question we'll be asking you. This is a practical problem. Now, this is because, what they have found is this suddenly pain relief occurs. And it is a very rapid pain relief when you give intrathecal route. That is an advantage, but that can also produce, suddenly what happens is there is a decrease in the circulating level of adrenaline compared to noradrenaline.
Okay.
Adrenaline will still be there, but adrenaline suddenly comes down. And the effect of noradrenaline on the uterus will predominate. And the effect of noradrenaline is mainly alpha effect. Alpha effect on the uterus is constriction of the or contraction of the uterus, whereas the beta effect of adrenaline would have prevented it. Now, sudden, imbalance in the circulating levels of adrenaline and noradrenaline. Noradrenaline is more compared to adrenaline because of the sudden pain relief. So that produces sudden contraction of the uterus. Uterine hypertonicity of the uterus will occur transiently. And that decrease in the blood supply to the fetus, and that can produce fetal bradycardia. So it is a transient phenomenon. You should anticipate this. You need not have to do anything for this. You just inform the mother and the obstetrician about this.
Okay, sir.
Okay. So, okay then. We'll meet again tomorrow. Again,
Yes,
5. Okay.
Okay.
Thank you.
Thank you.
Nicely answered. Okay. We'll see tomorrow. Right.
Thank you, sir.